guess what I have to do though is pull up the comments section real quick. So 1 second. Did you actually email me the link, Jasmine, or is it just in Target?
It's just in Target on the top right-hand side of the screen. Do you want me to email it to you?
Yeah, if you could.
Coming your way.
Thank you. Actually, email me the link, Jasmine, or is it just in Target?
It's just in Target on the top right-hand side of the screen.
Got it.
Do you want
yeah, if you could.
Coming up.
Jasmine, you got to mute your YouTube.
Email me the link, Jasmine, or is it just in Target?
It's in Target on the top right.
That's better. Yeah, that'll work too. All right, we're sorry, everybody. We'll get started in just a second. We are just trying to get your comments box up here so that we can answer you. Perfect. I can play some music in the meantime. I can't actually hear you, Chief Cepetto.
Oh.
Now I can.
Okay. Is the comments box is on YouTube?
Yeah, so if you open the link that Jasmine sent out, then make sure that you're either pause the YouTube or mute it, and then the comments box will be off to the side. And there's a little thing you can do to pop out the chat. So if you want to put it next to you on the desktop. Nobody's saying anything yet, though, so. Excellent. All right, somebody who's watching, say something in the chat so we know it's working. There we go. Thank you, Chief Kern. No, I don't want to. I want my beard back. I have several more days before I have to put a mask on again. Hello, Julie. How are you? Okay, good. All right. So in the comments, can you all hear me? And then make sure you can hear Chief Jameson and Chief Cepetto as well, if you guys want to just say a couple words so they can hear you.
Good, Chief.
Good here.
Good here. I can hear everybody. Everyone can hear me.
Fantastic. Yes, thank you, Doug. Okay, looks like we're up to about 60. We'll give it just a couple more minutes for people to join. Thank you, Chief Tokars.
You can hear me too.
Awesome. All right. Thank you, John. Jasmine, I'm going to throw a document up just to make sure I can share my screen, okay? Make sure these guys can see it. Chiefs, can you see that?
Yep.
Yeah.
All right, very good. Becky copies our copy. Very good. All right, and next in the comments, just make sure you can see the dispatch document that's on my screen. Make sure we can show you guys this. We're trying some new technology today to try and make it smoother. Looks like people are still coming in. So once you guys tell me you can see this document on the screen, Is that a thumbs up for the document? Okay, good. All right, thank you. So check that for a second. Excellent. Okay, so looks like we've got a fair number of people checked in, so we'll go ahead and get started. And try not to go too long today since it's Friday. So first of all, thank you to Jasmine for arranging this with a new technology. Hopefully it'll be a little bit better in terms of the quality. And thank you to Chief Jameson and Chief Cepetto for joining. And away we go. All right, so today's updates. First of all, the Florida case counts. Refresh the window. Okay, hopefully you guys can see that. We have 9,585 cases in the state of Florida, with 163 deaths in Pinellas County. We have 289 cases, with 7 deaths and 58 total hospitalizations. There was a question last time about whether that's current or total hospitalizations. That is total hospitalizations. I'll give you the current stuff here in just a second. But you can see these numbers continue to rise. And just for a quick comparison, here's our age distribution of cases. So we are seeing, now that we're testing more, we're seeing more in the younger population as well. The next thing I will show you is, actually, I won't show it to you. I'll just read it to you. The next thing is our current numbers here in Pinellas County. Got to get to my email, sorry. Too many emails, I'll tell you that. Okay, so currently, as of yesterday evening, we have, if I'm reading this correctly, 8 people were admitted to hospitals in the county for COVID and 1 was discharged from a hospital. There are currently 42 people hospitalized in Pinellas County, and 26 of those are in the ICU. 15 of them are on ventilators, which means that 62% of our hospitalized cases are requiring an ICU level care, and 58% of our hospitalized cases are requiring ventilators. Currently, the ICUs in Pinellas County are 65% occupied, with 12% of those being COVID-19 cases. And we are using 37% of our total ventilators, with 12% being COVID-19 cases. Overall, the hospitals are only at 40% occupancy, and a very low percentage overall of COVID-19 cases. So that's pretty much the situation summary. That's where we are right now. And with that, I think I'll go into where we're headed next. Throw any questions you have about those numbers or statistics in the comments. Actually, I want to show one more thing for situational, which is the here we go. Show one more. All right, University of, no, I don't have that vent-dependent data quite yet, but University of Washington has a modeling place that's doing really, really good work. This is for the entire country, and this assumes continuation of full social distancing type interventions. And so what you see here is this is the curve that we expect to follow. So this will be all cases, or all admitted patients. And so at a peak, we expect there to be 250,000 people in the country that are hospitalized for COVID, with at a peak somewhere around 40,000 plus on needing ventilator. And then if you drill this down to Florida, and again, the website, hopefully you can see up in the bar there, but it's covid19.healthdata.org. If you look down here, you can see our peak in Florida is projected to be a bit later. So still almost a month until our peak. And that would be a function of the fact that we've been doing social distancing for a while and have sort of pushed this back a little bit and hopefully been a little bit effective in terms of flattening the curve. And you can see that it looks, according to these models, and again, these are models assuming that that social distancing and isolation and all that stuff continues, that at our peak will be maybe 2,000 ventilators, and hopefully not have a shortage. It looks like we may have some ICU bed shortages, so we may have to flex into many more ICU beds from other places in the hospital. The hospitals are considering things like PACU beds and other outpatient surgery centers that could flex into uh, a temporary ICU. This line here is supposed to be, this is how many beds we actually have. So there's projected not to be too terrible a shortage here if the low end of the projection holds, but if the high end of the projection goes, you can see the range is wide. So it could still go into resource shortage in terms of all beds, ICU beds, and ventilators. But this projection is actually also interesting and sort of troubling. This is the projected deaths per day, and you can see these numbers here have already been filled in because they are updating this model when the data comes out from real time. And so we would expect to see our deaths also peak right around there, with an anticipated peak number of 175 deaths per day in the state of Florida, and a range of anywhere between 31 and 529 deaths per day in the state of Florida. So their best guesstimate is 175 deaths per day at our peak, and then it would trail off over a significant period of time after that, where we would still be having significant numbers of deaths, which would project a total of almost 7,000 deaths in the state of Florida from COVID. So this is the best data we have right now. And again, I know that the question is, and this is a good question. So there's a couple of different people are asking questions, and it's sort of the same question, just maybe asked different ways. So Jessica says, what are your thoughts on the prediction of Florida not peaking until next month? And some other folks said similar things. And basically, I think it's important to bear in mind that any kind of social distancing activity is expected with the incubation period of the virus to take 2 to 3 weeks to show any kind of result. So if you start social distancing today, you would not see the effect of that, even the beginning effect of that, for several weeks. You take that combined with the long incubation period where somebody could be a week or more before they're symptomatic. You add asymptomatic spread, and you add the fact that the natural history of this disease is a very long disease course that lasts several weeks, and people can actually deteriorate further on in their course and not require ICU care until maybe they've been sick for 2 weeks or more, or already. The peak is going to lag behind any kind of testing numbers that you see. So the testing numbers are sort of interesting, but they're probably not a particularly hard measure that we could make inferences from. So to my mind, the number of people that are coming into the hospital on a daily basis and the number of people that are occupying vents and ICU beds in the hospital is probably about as hard a number as we're going to get to know where we are on this curve. Because any kind of testing is limited by how many people you tested. You didn't test the entire population of the community, so you don't really know what that number actually is. So this is a website that I think is very useful to look around on and kind of help understand what may be going on here. Okay. So next, we'll go quickly through some of the work that's been going on this week in terms of preparing the system. And I want to preface this by saying very clearly that these are draft protocols. They are not in force yet, and they are not allowed to be followed yet. They are very much draft protocols. And so I don't want anybody to misinterpret that these things are live now. They are still going to go through an approval process with the medical control board on Monday, and all of that. So these are very much drafts that I'm going to show you, but I do think it's worthwhile. And Craig and I kind of walked through this on Tuesday with you guys about where things are planning to go. But now that things are being nailed down a little bit more, and we're kind of getting everything ready here, I thought it would be worthwhile to share with you. So I'll start with this first one, which is dispatch and response plan stuff. And so if you don't know, there's a unified command structure in place for this event in Pinellas County. I think we mentioned it last time, but I'll just mention it again. It's got a fire chief, an EMS chief, the director of operations from Sunstar, County 500, and myself. So right now it is Chief Slaughter, Chief Womack, Richard Schomp, Craig Hare, and myself. And that staff may rotate at some point if we all get too tired with other people stepping in, but that's the current unified command structure. And based upon a lot of work and a lot of discussions with a lot of folks, this is the general outline of the response configuration. So currently, the standard response configurations will all remain in place. COVID-19 special rescue units may be added, and you've probably seen or heard a little bit about that. The goal of that is twofold, is to take up some of the surge, but also to make sure that we get as many of the COVID calls to those units to protect the rest of the workforce from those exposures. I'm under no illusion that we'll get all of the COVID calls there. So everybody needs to be ready to do this, but that's the goal there. We do expect at some point that condition 2 and condition 4 may be called upon in order to facilitate management of high call volumes. Condition 5, which is what we do during hurricanes, where the calls get shunted to the local city or district emergency operations center. We're not supporting that right now because we want to manage all the transport units at a central area for consistency and coordination. So the plan is that at a certain point, the transport units will, whether it's a rescue, a special rescue, or a Sunstar ambulance, if we get to the point where every transport capable unit needs to be used, that would all be managed centrally by the unified command, as opposed to kicking that out to 20 different emergency operation centers. We are going to probably turn on card 36 of the medical priority dispatch, which is a new card in the dispatch protocols, and it's designed specifically for the pandemic, and they've actually just revised it specifically for COVID-19. So it's actually turning into a pretty useful tool for us, and that'll help dispatch process these calls, get the appropriate resources and the appropriate speed notes. This is probably a really important one for everybody to pay attention to, and it's already actually in effect. The current pandemic level is displayed on the hospital status board that you all know how to look up to see what the status of our hospitals are. So you can always know real time what our status is by looking at that board. Quickly, the 911 call takers are going through this EIDS stuff. It's not really necessary for us to go through most of it right now because it is unchanged from what's currently happening. We are going to be asking people to bring the patient or come out, if it's a first party caller, out to the front, just like we're doing with the hospital handoff. And because we heard back from you that that can create more confusion if you don't know whether that's actually happening, we're going to ask the call takers to place a note in the CAD if they have agreed to come out. So we'll see how that works. We may have to change it as we go. And we're also going to have them tell folks who are calling from facilities that, we're screening all of our folks. But again, the ask would be to be courteous and comply with what the state is mandating that all of our skilled nursing and assisted living facilities do in terms of screening people coming in. These are the response configurations that come out of card 36. If any of you guys are really into dispatch, you'll understand what this means. But it basically means that as we are currently in condition yellow, you still have a full normal system response, and then we supplement with a COVID-19 special rescue if we have one available. And then I think it's worth noting that on an alpha call, the system unit can cancel once the SR is en route if they choose. But for Charlies and Deltas, we wouldn't want you to cancel off just because you see a COVID unit is coming until you actually have gotten on scene and looked at the patient and make sure they're not in extremis. Because again, those are higher determinants. And then you see as we progress through here, the resource allocation to these calls change. And by the time we get to condition black, which again, we hope we never do, basically it's going to be the closest unit, whether it's ALS, BLS, that we can find to send to the person, just as it was during the hurricane last year. So this gives us the flexibility to manage as we go through, and simplicity for the dispatchers to kind of keep things moving in the right direction for us. So that's the first piece. I guess you can take any questions about that if you guys have them. First one is, what is the trigger to go from yellow to red? I may have missed it. So that would be based upon the pandemic plan and based upon the unified command and the executive policy group from the county. The types of things that go into that, we can share that document with you next time that lays it out if you haven't seen it, but the type of things that go into it are how much stress is on the system in terms of call volume, how much stress the hospitals are under, scarcity of resources, essentially when we really as a system start to get stressed. Think like system status management during a busy season in the spring, and then some, and then we would start to proactively manage things and move from yellow to red. Obviously condition black is when we're really struggling to hold things together. So that's the first piece. The second piece, I'll skip for now. It's about PPE, and you guys have all pretty much seen it already. So it'll be the same thing about how to do the standoff, how to, what appropriate PPE is available, et cetera, and how to minimize exposures. The next one I'll show you, and again, I need to emphasize that this is a draft. This is not approved for use yet. I had hoped to have all this done for you today, but the fact of the matter is, we had a lot of clinical changes over the last few days with what we're learning from folks in other parts of the country. So here is the draft, and again, it's draft, clinical standards protocol for the COVID-19 event. And the first thing I want to emphasize is here is that any patient who meets screening criteria who you suspect COVID in, please do us a favor and document suspected COVID-19 or confirmed COVID-19 in the narrative so that we can catch these calls for surveillance. It just helps everything if we can have you guys consistently putting that into the narrative. And I know based upon our last several years experience with First Pass that you guys can do it if you want to. So I'm asking you to please write those words in the narrative and help us out in terms of tracking these patients. The next thing is the protective actions that we want you to take on all patients. So first, you're going to protect yourself by using the standoff, appropriate PPE, minimizing personal items that you're bringing into the patient care areas, and double gloving for aerosol generating procedures. We're going to minimize spread from the patient by putting a surgical mask on them. If you're giving a nasal cannula or a non-rebreather mask, please put the surgical mask over the top of that to keep all the aerosol in. And then we'll have you wrap them up in a blanket if we can. Also, we want to use distancing, shielding, et cetera. So we want to move non-essential people away from any aerosol generating procedure and place barriers in between, or even perform outside if you can, so you don't have the aerosol in a confined space. It may be helpful to use the exhaust fan in the ambulance compartment and then turn on the air conditioning in the front so you keep airflow moving from front to back of the unit. So those are the general things. We really want you to do those on basically every potential COVID patient at this point. I do want to cover a few of these pearls. And again, this is draft, so it's not like you can take this and go use it tonight. So I just want to walk you guys through, and hopefully you'll have some feedback and suggestions for how to improve this before we finalize it over the weekend. So number one is that we're hearing more and more and more that COVID-19 patients present with hypoxia that is shockingly bad numbers to the people taking care of them, but that the patients don't actually look that bad or actually don't feel that bad. And this is starting to be referred to as happy hypoxia, which is a very, very strange term. But people are apparently walking around with SATs of 70s and 80s and doing okay. Unfortunately, at some point, then they suddenly deteriorate is what we're hearing. So what people are struggling with is that we need to guide when is it time to be more aggressive with airway management more based on work of breathing and mental status than with just respiratory rate or SAT alone. And so that's going to be a little bit difficult for us. It's going to change our paradigm about how we assess these patients and what we think about them. That's number one. Number two is that our general approach is probably best to be to try and temporize these people with supplemental oxygen. When this first started, there was a lot of discussion and even guidance put out that you titrate them up on oxygen to 6 liters. And then if that doesn't work, you go right early to aggressive early intubation. And now there's some thought that that's actually potentially detrimental, and it may be one of the reasons that Italy has such a high mortality rate is because they were aggressively. Wow, look at that! The Chiefs were drinking in unison there. Are we playing a drinking game? Did we turn this into a drinking game? No, not
I want to.
by the end of this thing, we might, right? So there's some thought now, though, that the early intubation of these folks may actually be detrimental. And so if we can nurse them through on the oxygen to the hospital, that's probably our best strategy. We're also beginning to hear reports, this is early yet, of some upper airway edema, but having open cords. And this could actually make tubing these folks a bit difficult. So we have been around the block on this. Is the problem is that performing an endotracheal intubation on these patients is what we first thought was going to be the best thing for them, but now we're not sure that that's the case. It might be that that's actually not the best strategy for them. And B, the actual procedure of doing the intubation is extremely, extremely risky for the provider who's doing the procedure. I think there's some data, and I don't have it in front of me, so I'm going to try to remember it correctly, but I could be wrong. Somebody can correct me if they have it. But I think back during SARS or MERS or one of them, it was like a 17 or maybe 13 times more likely if you intubated somebody that you would get exposed and develop the infection. So that's an incredibly high level of risk to take for these folks. Oh, the comment sections have really deteriorated with the drinking games. Sorry, shouldn't have said so. What I think our best approach probably is to temporize them on oxygen as best we can, and at the point where we don't think that's working based on respiratory rate or mental status, move rapidly to placing a king tube. And the reason to do that is because BVM with an external face mask is going to leak a lot of air and be a lot of aerosolization, and the endotracheal intubation may be difficult. And so risk benefit for the provider is probably to just get a king tube down, which would almost work like an internal BVM mask. And then we're working on potentially some shielding for that. Put a viral filter on the top of the tube, then your end tidal. And then between the vent circuit filter or viral filter that you can put on top of the king tube and the exhalation valve filter on the BVM, we should have about as closed a circuit as we could get without doing a full endotracheal intubation. And I'll get to it in a minute, but I think I am going to say that it would be okay to use facilitation for a king tube on these folks to minimize risk to the provider and maximize the speed of the procedure. I think we are going to say that. We'll see what the medical control board says on Monday, but I believe that that's where we probably need to go. I do want to give the caveat that best practices are changing very rapidly. And even over the last 48 hours, I've had to rewrite this 3 times with everything that's coming out. So it certainly would be not unanticipated that this will change when we learn more about the disease. We do not expect to see large numbers of severely ill pediatric patients. So we're going to try and do our best to preserve the standard of care for them as long as we can. But at some point that may become difficult as well. All right, so I'm going to stop there for a second and answer a couple of these questions. Yes, in the healthy hypoxics or the happy hypoxics, a large number need intubation within 1 to 24 hours. And that's correct, but I would sort of rather that intubation gets done by somebody at the hospital in a negative pressure room with a video laryngoscope and some paralytics potentially, and minimize that risk to us. If the patient can wait until then, why would we want to do that in the uncontrolled environment that we're in without all those fancy tools and stuff? I'll tell you, the hospitals are really struggling with how to best intubate these patients. And if we can temporize them in and allow that to be done in the controlled setting of the hospital in a negative pressure room, that's probably a much better idea. But that is a definite concern. Yeah, Chris, it is true. CPAP may be better than the ETI or King tube, and all of that. So the problem is the CPAP is extremely high risk for us as well, in terms of, we all know that there's always some leak around that mask, and that's going to be pushing virus particles out there in an aerosolized form. So I think the safest thing that sort of is along the risk benefit is to probably go ahead and just get the King tube in them and almost treat it as an internal CPAP. And there's a lot of talk that they can actually run BiPAP vent settings through a King tube, so, or an endotracheal tube for that matter. So just you know, again, this is going to evolve, but this is the best guess I have at this point about the right thing to do for these folks. So we would get the King tube in them, and we would support their ventilation, maybe by increasing their FiO2, and then by giving them a little pressure support sort of synchronously with their own respiratory rate with the bag. So we'll see how it goes. We may certainly have to adjust this over time. Next one is suspected COVID and EPCR for any patient that meets screening criteria as per the dispatch or as per our clinical judgment. As per your judgment when you look at the patient. The dispatch notes will already be in there, but once you get there and look at the patient, if you think they have suspected or confirmed COVID, then please write those notes. The bubble hood vents we've seen in the Italy photos. So those actually weren't vents, those were CPAP. They're called helmet CPAP machines. Excuse me. And those are not widely available here, but people are working on them. There is actually a company in Texas called like Aqualung that's working on it as well, which is more of actually a helmet ventilator. They have millions of orders already, so I don't know if we'll end up getting any or not, but Douglas, so it's like an airway erector set. Yeah, you don't want your ITD back like we used to do on the cardiac arrest, and we build the Leaning Tower of Pisa on top of a tube. No, so what we want is we just want an extra filter there. That's all. It's the only change is we're popping a filter in there to try and capture as much as we could. The PEEP valves, again, Jacob, is along with the reason for the filter is so that we don't get a lot of side streaming of virus containing air through the PEEP valve. So we're still working out how that would look. High flow nasal cannula is apparently super risky. So we don't want to go much more than about 6 liters on the nasal cannula, or else we're going to start aerosolizing and diffusing stuff all over the place. And then still no thoughts on starting with CPAP. Well, again, CPAP is super risky. And so that's why we're probably going to avoid them. I will say the protocol that we've got for condition yellow still allows you to try that if you want, but only with extreme caution and knowing that that's a risky procedure you're doing. Even with facilitated King intubation and giving Versed, wouldn't the likelihood of vomiting still be very high? It may well be, but you do have the OG port. We're working on seeing if we can figure out viral filters for the suction. And then PEEP valves, yeah, we talked about, we're looking at that. What about the face mask CPAPs? Well, the problem with those, again, is that the seal on those is always difficult. And so very, very high risk based upon the data that we have that those are, that doing the oxygen powered face mask CPAPs are pretty high risk to you guys. So I want to get into some of the details of what we're going to be proposing in the yellow here. And I'll throw it up on the screen so you guys can see it. So the idea is that you'd have this sort of laminated card with adult on the front and pediatric on the back. And before I do that, though, actually, maybe I better go up here and clarify the last thing here, which fell off the screen, which is super, super important. And that is the crisis and disaster standards of care dictated by the risk-benefit ratio and availability of resources. Condition yellow, where we currently are, warrants risk management because we still have available resources. The hospitals are very empty right now. Our call volume is down. We've got adequate PPE supplies. So risk management steps are clearly warranted, but alterations to the standard of care are less warranted when we're in condition yellow because we're not really being overwhelmed all the way. Condition red and black then therefore warrant actual alterations in the standard of care. And again, the current condition will be displayed on the hospital status board. So I think it's just very important for everybody to remember that we are category yellow right now. There has been no alteration in the standard of care. We're going to try to do some COVID-specific tailoring of our treatment protocols, which we'll get into in a minute, and we're going to try and do everything we can to minimize our risk as we care for these patients, but there is no change in the standard of care. So we've had a couple of things recently where people have kind of got tunnel vision and have missed other things that were going on with their patients, whether that's a STEMI or whatever else it is. And so we do want to make sure that that we're not missing that stuff and not getting tunnel vision on the on the COVID stuff. So here's the yellow, and I understand this is probably small on your screen, so I'll zoom into the one in a second, but I just want to show you it's going to be like a front and back kind of card. So you'll have this available to you to help. Hopefully that's big enough for you guys to see. So again, this is the adult only card. And again, it's a risk management and COVID-19 specific clinical care. It's not necessarily an alteration in the standard of care. So we know a couple of things in sepsis. We know that aggressive fluids can precipitate respiratory decline in these patients. That's what we're learning. So we want to limit our initial fluid bolus and then move rapidly towards levo if that's what we need. Solumedrol turns out may be harmful in these folks, so we're going to defer that to the hospital to make that decision. End-tidal CO2, we're going to put that filter between the king tube or the endotracheal tube and the CO2 device. And we're going to go closest appropriate hospital for these COVID patients so that we don't have extended transport times while we're in PPE and being exposed. And then each one of these separates out the aerosol generating procedures. You're welcome, Stephen. And what protective actions, obviously above and full PPE, and then what we're going to do. So this is sort of the pathway for oxygen is supplemental oxygen with permissive hypoxia. So we want to get a SAT at least of 85 instead of maybe at least of 94 if they're able to tolerate that without severe distress or altered mental status. And we're going to do that by doing nasal cannula up to 6 liters under a surgical mask. If that doesn't work, we're going to switch over to a non-rebreather under a surgical mask. And then if they have wheezing or bronchospasm, we're going to skip the nebulizer because that is incredibly high risk, we think. And instead, we're going to use an MDI if they have one. So if they have an albuterol puffer in their house, grab it and use it. And you can give them 2 puffs every 3 minutes to a max of 10 puffs. And please bring the MDI to the hospital. They're going to need that in the hospital too. The hospitals are going to want to use the meter dose inhaler just like we are to avoid the nebulizer, but there's not a ton of them available. So if the patient has one, bring it with them. And then if that's not working, we can go ahead and give them some intramuscular epi to relieve the bronchospasm. So epi, so there's a question from Crystal. If the patient is an extremist but also tachycardic, would it be appropriate to do med consult going straight to MAG rather than epi-IM? So you could. MAG, epi is going to work a heck of a lot faster than the MAG is. And we don't have a ton of MAG available. We have a pretty good supply of epi. But epi is really going to break that bronchospasm for you a lot quicker and better than the magnesium probably will. We'll talk about MAG when we go a little further down here into the other colors. But this is sort of our basic strategy for dealing with nebulizer. And then again for suction and CPAP, we're going to try to minimize the use. They're not prohibited in category yellow. So again, the standard of care hasn't really changed. We're going to try to minimize their use for protection of you guys. And obviously, if you're going to use it, please make sure you're in full PPE and taking all appropriate protective actions. So remember, we said last week that we want you guys in the full PPE anytime you suspect a COVID patient, but also anytime you're doing airway management, any aerosol generating procedure, or a cardiac arrest for this very reason. The BVM, again, we're going to try to minimize how long we use it and go right to the King tube if possible. And on the King tube, we're going to allow facilitation meds if needed to get that thing in as quick as possible. And we're going to ask you to try to make sure it's seated as well as possible prior to start to squeeze the bag so you don't get a lot of blowback from it. Intubation, again, is also high risk. Avoid if possible the other strategy we talked about, but it's not prohibited because, again, at category yellow, the standard of care is not altered. Again, though, make sure that you inflate that cuff prior to ventilating them so that you get as best a seal as you can. And then crike, again, would be extremely high risk on these patients. All of you that have done a crike know that there's definitely aerosolization of blood that happens during that process. So please, if you're going to have to do a crike on somebody, which fingers crossed we don't have to crike a COVID patient, but if you did, please make sure you've got full PPE on and as few people right there as possible and all those protective actions that we talked about. And then in CPR, we do want to also use extreme caution, definitely an aerosol generating procedure. And we would entertain an online consult for cessation earlier than the 20-minute mark in a COVID patient if you felt like that was the appropriate thing to do. So that's the general approach that we think we're going to be able to release to you on Monday or Tuesday. Again, to be clear, this is a draft. This is not in force right now. Please do not go out and facilitate a King tube over the weekend without talking to an online doc. And then this is the pediatric version. Again, it looks very similar for all of these initial actions, as well as the sort of escalating through the supplemental oxygen, the nebulizers, and clearly we don't have King tubes for the kids, so we may have to BVM or tube those folks. We would also entertain, obviously, a consult for cessation in a pediatric COVID patient as well. So I'm going to pause there and see what kind of questions we've got on that. What are your thoughts on passive oxygenation during a cardiac arrest? So yeah, that can be helpful, but in this scenario, that would increase your aerosol generation. So I'm not sure that we want to be pumping high flow nasal cannula up the nose at the same time we're pumping on the chest and kicking virus particles in an aerosolized form back out. So I'm not sure I would advocate that in this particular scenario. And again, that's actually a really another point that needs to be emphasized, that these specific actions and protocol adjustments apply only to suspected COVID patients. They don't apply to a non-suspected COVID patient, right? They apply only to suspected COVID patients. We've got plenty of other people who are just having their normal broken leg or car accident or STEMI out there who still need the regular standard of care. Next one is, if in extremis, but also tachycardic, would be appropriate to do a med consult. I think we covered that one already on the MAG. With a hypoxia patient that we intend to facilitate a King in, would you consider push dose epi, say 20 mics prior to sending the King in? Do you mean in a hypotensive patient? No, he said hypoxic. I'm not sure what the push dose epi would get you for hypoxia there, La Femina. If they were hypotensive and you're switching them over to positive pressure, that would make maybe a little bit more sense. Oh man, that is a great question, Aaron. Yeah, I would inflate the tube on a PD cuff. We'll have to put that in here. I'll add it to my list. What a great, great, great suggestion. I'm gonna write that one down. Good, great suggestion. Thank you, Aaron. So that's basically what we think is going to be the guidance in terms of how to best care for COVID patients, balancing that with how to protect ourselves as much as possible. And then Pilash says, aren't all respiratory precautions patients suspected COVID patients? Yes, they are. But a chest pain without respiratory precautions that has nothing whatsoever to do with an infectious thing is not. And therefore, that patient should get the normal standard of care. You can certainly, you can, Chris, you can certainly uh, use additional protective measures like PPE if you're going to be doing an airway or something else on a non-COVID suspected patient. And we want you to do that for the sake of the asymptomatic carriers, right? To protect yourself from that. But if it's a non-COVID suspected patient, we certainly want to uh, make sure we're still upholding the normal standard of care. Yes, I'm sure that will definitely explode their neck, Chris. And Ryan, yeah, we'll try and nail that down. Okay, sorry about that. Okay, good. So that's yellow. And then once we get into red, this is where the standard of care would then actually justifiably be beginning to be altered. And I'm sure everybody is going to absolutely love this first one. Julie, are you on there still? First pass quality measures, we would go ahead and give you a pass on while we're on category red. And this is actually what that MCI disaster overall exception reason was built for. So we're going to go ahead and use it so we don't have to spend time reviewing charts and stuff. Now, that doesn't mean that we don't want to try to provide the best care we can, but it means we're not going to go through all that process as we do on a normal daily basis. So we'll just go ahead and do that same way we did in the middle of a hurricane. This other stuff remains the same, but again, because now we're in category red, we actually will alter the standard and say Solumedrol is not to be given to any suspected COVID patient. You're welcome, Julie. So that's why here, and once we get into red, you start to see things saying not indicated, do not perform, as opposed to avoid if possible or use caution. Mitchell, yeah, we're already working on that, man. Doug, do you really think it's Big Brother? How many people do you think read every chart I write in the hospital? It's 2020, for God's sake. This all stays the same here as well as here, except that we will expressly prohibit NEBs instead of saying try very hard not to do them. We will go right to the MDI if they have it, or right to epinephrine. We tried to see if we could go old school and get you guys some terbutaline, but no chance of getting that right now. Pretty much every drug in the world is on national back order and shortage right now, so we should just expect that. Suction again is problematic, so that's there. CPAP again, we're going to actually prohibit in condition red again because of resource scarcity. If we're in red, we may be getting short of PPE. We may be having to mitigate as best we can. BVM, again, we're going to have the same strategy rapidly through to the King tube placed with facilitation if needed. And then we would actually prohibit intubation or crike of these patients. Attempted resuscitation, this is an important one because this is a significant alteration in the standard of care, would be that we would attempt resuscitation only if our initial rhythm was VFib or bystander CPR was in progress, and we would consider early cessation if no ROSC after 3 shocks and 3 EPIs. So if we're in condition red, we can't spare the resources and the exposure to work a full 20, 30, 40-minute code on these folks. And we can't do that for somebody who's clearly not going to have a good outcome. That would be the limitation there. The pediatric one looks similar, except we don't have the King tube, obviously, and we would not ask you to withhold a resuscitation effort on a pediatric potentially. Let's see. Okay. We'll answer a couple questions here. Yeah, I suppose we could make a impression or checkbox for COVID-19. I know people are talking about it. Stand by. We may get it. For right now, I have every confidence that you guys can actually spell the name of this thing right now. I know that decisional capacity is apparently hard to spell, but this one, I feel like you've probably seen it enough to be able to spell it. So hopefully we get that. Bring the precordial thumb back. Whoever took it away. It's only ever worked once for me, but it was amazing when it did. Um, it's only 5 letters and 2 numbers. Thank you, Julie. I feel like you should do the Sesame Street count after that. 1. Ha, ha, ha. So, big word. Yeah. Okay. When are the viral filters coming? Very soon, I hope. I hope they'll come out very, very soon. I know we have some and more ordered. CPR protocol, if I understand, is where New York City currently is. Yeah, pretty much. Or maybe even more aggressive than that. But yeah, I did talk to some of my colleagues up in New York about what they're doing with cardiac arrests. Yeah, and it is not a hypothetical concept. It very well, I think there's a real possibility we could get to red. I really, really hope we don't get to black. But I think there is a real possibility we could get to red. Paramedic initiated refusals. So I know you've asked who is Pilasho 5 anyway? Somebody, who is that? No, I'm just kidding. You don't have to call him out. You've asked for that a bunch of times. I'm going to show you the draft protocol, and we are not calling it a paramedic initiated refusal. We're calling it shared medical decision making. But I will show you that after we get through this. Anthony, restate your question. I'm not sure I follow what you're trying to say, please. And then pre-hospital ACE inhibitors left for the at-home recovery protocol. Why would you do that? There's at least anecdotal evidence out there that ACE inhibitors might actually put you at higher risk. Although every single major society has recommended not changing if you're already on an ACE inhibitor. What's a dash? And a dash. I don't know what that means. All right. Yes, I do think there's a good chance we will see condition red. I don't know for sure if we will or we're not, but maybe. Okay, so on an alpha patient with a COVID SR responding, no critical interventions needed based on general impression. Does the first responder still make contact and ride into the hospital? If you're already there, certainly we'd want you to get, the eyes on the person. You can maintain the standoff. I think it would probably be fine. But the idea of the first responder riding in is about having 2 people in PPE who can handle the patient from start to finish, and we don't have to burn other sets of PPEs. And that's just the way that the chiefs decided they wanted it to do. Okay, so I think as the COVID SRs come out and take effect, we'll find out better how they mesh into the system. And then clinical services, can you expand upon the ACE inhibitors comment? And Anthony, if you want to expand upon or restate yours. And while we're waiting for that, I will scroll down to the condition black. Now, this may or may not be difficult to wrap your head around. It's certainly a significant issue. If we're in condition black, things are not going well for us in our community. And if we're in condition black, the standard of care change may not just be for COVID patients, because what I'm hearing from folks who are ahead of us in this is that there's no such thing as a non-COVID patient anymore. Every patient that they see has COVID. So that's certainly not where we're at right now, and that's a good thing, but that is something to consider going forward, and that's why that note is. And in this case, again, we'd have all the same things up here. We'd still do our permissive hypoxia. We would do the MDI, and I would say it'd be fine to go ahead with the additional online options of additional epi and mag without talking to online. And then we would say that CPAP, BVM, King tubes, endotracheal tubes, and CPR would be not indicated. So basically, we would do some basic stuff, supplemental oxygen, and take them to the closest hospital or alternative destination, which could be tent or field hospital or whatever it might be. Is New York in condition black? No, they're sort of teetering on the brink between red and black, is my understanding, at least from a day or two ago, the last time I talked to somebody up there. Under condition red, if we have an issue with a king insertion, are we able to use an endotracheal tube, especially if they were already facilitated? Yeah, I mean, I guess nobody would probably fault you for that. It certainly wouldn't be ideal. The level of exposure and resource that you would do would be pretty extreme in that scenario. But if you chose to do that in front of your patient, I guess I wouldn't necessarily fault you for it, but tough decisions. How many COVID transport units are we currently planning to outfit? This is assuming we make condition red. I think that's still up in the air, Stephen. That's an ops question, and I don't think I know the answer to that. I don't know if either of our chiefs know the answer to that either.
I know there are a couple that are being considered. Clearwater made mention of doing one collaboratively with Safety Harbor and Largo, and there's some talk among the North County units putting one together as well. I'm not sure from the Sunstar side if they're looking to expand on that now.
Yeah, I think that's going to evolve over the next week or so. The units that were out there this week were sort of part of a pilot test program to see how it would work. Okay. And we'll just go to the black and show you what it looks like again. And then the pediatric black is a little bit more permissive. So that's the general gist of it. Again, to emphasize, these are drafts. These are not in play right now. Please don't go out and say, oh, I thought we were condition black and I didn't work the code. Please don't do that. If you guys do have any suggestions for this, please throw them in there. Would certainly like to have your feedback. I've already had a couple of good ones that I've written down. So please, please, please.
Other thing that we're looking for is items of confusion. If you are looking at this and you're not understanding it, or something comes up about that, make sure you shoot me an email and we can look at that as well.
Yeah, so that would certainly be helpful as well. I haven't heard anything about military medics coming here, but who knows what will happen as the situation evolves. Okay, so let's, for the sake of time, keep moving here. The next one is, again, also a draft. So I do not want you to implement this, and this would not even be implemented until we get to condition red anyway. No, Mitchell, you can't have them on Target Solutions because they're still drafts. We'll get them out once they're finalized over the weekend. If you want to specifically see one, just email me and I'll send you the draft.
I want to make it clear you're asking for something in Target Solutions, right?
That's funny. Okay, so here it is. Here's the stay-at-home shared medical decision-making for suspected COVID-19 patients. This is adapted from a document released by the state of Florida DOH, as well as from some other EMS systems, like, say, New York City. And basically, it goes through inclusion criteria, must have all. So they have to have relatively, but not 100% normal vital signs, have to have decisional capacity. They can't be very young or very old. They have to be able to care for themselves and have a support system. They have to have a cell phone to be able to call for help or be followed up by the Department of Health. They cannot have any of these things, chest pain, anything that, other than just with a cough, any suspicion of ACS or CHF, respiratory distress, cyanosis, diaphoresis, syncope, altered mental, toxic shock, appearance. So that's sort of how they look to you. The look test, high risk underlying conditions, or you just are like, hey, you know what, this isn't cool. This patient needs to go to the hospital. As you know, I'm always supportive of you guys using your paramedic intuition. So we would then have a conversation with the patient based on that criteria, make a decision whether we think they're appropriate for home care or not. We would be providing them with some sort of discharge instruction like paperwork that says how to get more information, when to call for help, all that kind of stuff. And then we would do a version of a signature on there where we would sign for them with a witness, since we don't necessarily want them touching our computer. Any questions on this one? It's pretty straightforward, but it is there's a little bit of a change in how we do business.
So just for clarification, over 50 is really old.
Yeah, so of course, that's the question. Over 50 appears to be an inflection point in the risk for severe disease and or mortality. If we got to condition black, I would see us potentially bumping that up a little higher.
And on a cheery note.
Yeah. Yep. It's not the most uplifting kind of stuff. So that's what it looks like. Again, still draft. So please do not go out and do this tonight. That would not be a good thing. The next one I'll show you is the draft of the, yes, Alan, over 50. Sorry. So this is the, this is what we would, a draft of what we'd leave behind with them. So it just shows some of the things that we assessed on them, give some home care instructions, etc., suggestions on when to call us back or go to the hospital, contact numbers and resources for all these folks. So we are going to put this into Spanish and probably Vietnamese as well. Actually, I think I've already seen drafts of both of those. So anyway, just so you know, you'd have something to leave behind with them. We'd also have some DOH and CDC handouts to leave behind with them as well. Okay. Is the stay-at-home contingent on yellow, black, red, or will it be in place sooner than later? I don't anticipate it would be in play at least until we go to red, and maybe not even initially then. Just to clarify, we are being allowed to refuse these patients transport to the hospital even under this protocol when it's finalized. So I don't think we are refusing them transport. I think we are engaging in what's referred to as shared medical decision-making, where you and the patient have a conversation and come to a mutually acceptable understanding. This is a concept we do a lot in the hospital, and basically it is respecting their autonomy and involving them in the decision while you're acting as their advocate and as their subject matter expert to make them, help them make an informed decision. If they meet all criteria but really want to go to the hospital, then at least in the beginning, we would ask you to do an online consult before we even considered saying, no, sorry, we refuse to take you. It is past 5 o'clock, so that's why I'm trying to talk fast. Any changes to peds with respiratory illness? What do you mean? I'm not sure what you mean by that. So anyway, the last one is stuff about decon and what to do if you think you might have gotten exposed. And I'll leave it to you guys if you want me to go through the exposure risk stratification, et cetera, or if you just want to know that that's being planned for and et cetera. Can we have an additional signature prompt in the EPCR specifically for the, yeah, they are developing a specific signature block for that. Okay, so I think that's the bulk of what I wanted to tell you. I do have a couple of other things. Oh, good question. Any word on the study from Duke? Yeah, let me switch gears to that real quick. Okay, so couple things. And Chief Cepetto and Chief Jameson, if you could jump in on this with me. Um, First things first is the N95 masks. So obviously we've asked you guys to use a lot more N95 masks over the last week, and we certainly have. We've used a couple thousand of them. We still have a bunch in the warehouse, but we do need to be smart with our N95 mask supply. And based upon the good work that came out of Duke, we do think that there is a potential use for a aerosolized or vaporized hydrogen peroxide sterilization process with potential for reuse of an N95. And we're not saying we're going to do that yet, but we're saying we're going to start saving our masks in case that becomes something that we need to lean on, or in case a hospital or somebody else would want those masks instead of us throwing them into the landfill. So you will start to see recycling of N95 masks roll out over the weekend. And into early next week, and there will be a yellow bag or bucket that you will be asked to put the masks in for collection. So do not be surprised to see that over the weekend, and that would be happening at, I believe at the hospital decon areas, maybe at some of the stations, and maybe at Sunstar too. But the logistics are still being worked out, but I would say that will start being rolled out over the next couple of days so that we can actually capture those masks that have a potential for reuse.
And Doc, you want to touch on the P100s being rolled out?
Yeah. Did I say the N95 stuff correctly, Chiefs?
Yeah, I think so.
Yeah, I think so too.
Great. Concurrently with that, the fire departments will be moving towards P100 filter cartridge face masks or face respirators shortly as well. I know that both Dunedin and St. Peter are going to be probably in the first wave of transitioning over to that. And the reason for doing that is that we can get multiple day usages out of a single set of cartridge. And so we have a couple thousand of those cartridges in the warehouse and a couple thousand more out on the street already. And so that would be a very sustainable way to keep you guys safe as we go through this, even if our N95 mask supply gets stretched. So the general idea is that for the most part, Sunstar is going to be staying on N95s at least for a bit. They may slow roll into the P100 masks later on, but for right now, the N95 is primary for Sunstar, and that the FDs will beginning to be moving towards the P100 masks over the next several days to week or so. And the whole point of that is to maximize the supply of PPE that we have. Now, listen, you guys in the comments, don't make me put you in timeout, because I totally will. And don't also forget that this video is recorded and posted, and your comments will live forever. Just saying. And the decon procedures and storage procedures for the filters and the P100 masks will also be coming out. And I see that Clearwater is also going to be one of the first departments to be heading in that direction. All right. So the other thing that I do want to let you guys know about, and please pay attention to this one, because this is a significant change. And this is something that is different from what we told you last week, and is going to roll out over the next couple of days. And that is that if you used an N95, we said before that if you did not have patient contact, you maintain the 6-foot standoff, that you could reuse that N95 mask. And you guys did a good job of that. We saw a lot of reuse, but we also saw a lot of masks still being toasted, because we said anytime you're actually engaged in patient care, you need to get rid of the mask and get a new one for the next patient. And what we believe, and this is supported by the CDC and other bodies, is that if you wear the N95 mask and put a procedure mask, that's the little usually yellow one with elastic ear loops over the top of it to protect anything from landing on the mask itself, you can discard the procedure mask in between patients, but keep the N95 mask. And so what we're going to ask you to do is actually keep your N95 masks, and reuse them unless you have done a code, an aerosol generating procedure, or had a suspected COVID patient. So I guess the easiest way to boil it down might be if you've put on the full PPE ensemble, the whole thing, the gown, everything, then you would toast that N95. But if you have only just had the N95 with a procedure mask over the top and your goggles on, then you could reuse that N95 for the next patient. And you could probably do that for the whole shift, we think. So you would put one on, you would put the procedure mask over it. After the patient, you would get rid of the procedure mask, but keep the N95 mask, reuse it with a new procedure mask for the next patient. And then up until the point where you had an arrest, aerosol generating procedure, or you had a suspected COVID patient. And at that point, you would put the N95 mask into the recycle as you doff your full PPE. So shoot questions on that, because that's important and that's a big change. And it's going to be important to us in terms of maintaining our stockpile of N95s and stretching it out as long as we can with these predictions that we're going to be at this for at least another month or two. Tedesco, are you talking about as it relates to intranasal Narcan by chance? Mitchell, yeah, so there's a working group that is looking at exactly what we would do with the nursing homes if we get more than one cases in there, or more than one case in a particular facility. And that involves all sorts of stuff, but I'll just say that there's a group working on that plan right now. I don't think it's ready for sharing the details. Face mask erector sets, okay. Isn't there a 4-hour use limit on N95 mask? Well, yeah, technically they're single patient use, but these are extraordinary times. And the strategy of covering them with another mask and reusing has been very well documented. Again, as far as transitioning into the P100s, that's a logistics thing and for each agency is when they're going to start making that switch. But I do anticipate that will happen sooner rather than later on the fire department sides. Okay. I think that was the last of the stuff that I really needed to share with you all today. Just checking my notes here. Okay. So yeah, with that, any comments from Jasmine or our chiefs?
This is like watching a slow moving train come at you down the tracks from a mile away. So keep your guard up, wear your stuff, wear it right. And it's going to be a long haul. I'd swap this out for a hurricane any day, but here we are. We'll ride it out.
Yeah. Thoughts on possibly restricting thirds or partner back while patient care to stretch N95 supply, non-critical calls. Well, we've already taken students off the truck. And yeah, we do want to minimize the number of people involved in patient care when possible. But we do need at least 2 people to load and unload and safely transfer the patient. So that's why the other thing was going. Trying to think how best to answer the rest of that. There's some balance act to do there, because we do still need to be bringing people into the system and getting new people on board. So there's a little bit of a balancing act there. It's kind of like orientation next week. We are having an orientation, but we've made all sorts of changes to it to make it as low risk as possible. Any truth to Florida equipment being diverted to NYC? Read Tampa Bay Times article. Yeah, I've heard about that. I think the hard truth is that we may not get a lot of supplies in the near term from anything outside the state of Florida.
Try to separate from work this weekend a little bit.
Ambulance.
Hey, Doc.
Yes.
Hey, I just want to, reaffirm what Chief Jameson just said. This is very hard to continue this level of unpredictability and change that we're all going through. So everyone needs to just continue to be vigilant with that. The amount of change we're doing day to day, I mean, every day is a new thing. So everyone just needs to really keep that level up, and it's going to be hard and it's going to be really stressful. So just be mindful of that and watch each other for that stuff.
Yeah, I can't agree enough. If you are not feeling stressed right now, if you are not feeling like you're chasing a moving target right now, then maybe you're not paying attention, because I think everybody I know, for the most part, is feeling that way. But we are doing the best we can to make sure that everything's in place to keep you guys safe and to keep us providing the best level of service to the community as we possibly can through this. But there is no doubt that this is going to be a long haul, and this is going to be tough. You know,
A lot of information coming out. I mean, everything that you just went through was a lot. And I think it's very important for everybody to realize that these things could change really quickly. And if you just turn on, if we go red or black, things change very quickly. So you have to make sure that you're staying on top of your training. And if you have any questions, we can put out training videos on things, and we can answer those questions pretty quickly if you get them to us.
yeah, this is going to be, everybody knows the week before the hurricane is a lot of ways worse than the hurricane itself. But we have this like month before this thing hits. And then when it hits, it's going to not last a few hours. It's going to last weeks. So the aerosolization question, La Femina, or Rodriguez, I guess, asked it. Yeah, it's in that general protective actions at the top of the document there. So that will be the request. Got one via text message that says N95s only being reused if they are covered with a procedural mask. So yeah, that's the guidance right now, is that's how you protect it from transmitting stuff back to you or back to your next patient, is to put the procedure mask over it. So that's what we're asking. I know those are probably just now making their way out, so there may be a little bit of an implementation lag for that over the weekend. All right, we'll give you guys a couple more minutes to ask any final questions that you have. I will try to keep doing these updates regularly as we go through this, to try and keep you guys as informed as I possibly can. But Jasmine and the Chiefs are right. Things are changing fast. That clinical stuff, I rewrote it 3 times in the last 3 days, because that's how fast the information is changing. And the only way that we're going to be able to keep each other safe and do the best we can for our community is if everybody is eyes wide open, paying attention as we go through this. And 3 weeks from now, when you've been in a sweaty mask for a whole day for 3 weeks and you're just sick of it, it's going to be tempting to take shortcuts with your PPE. And I would encourage you guys to please take this seriously. We are seeing younger, healthy people. They're having real problems. And I'm hoping and praying that we make it through this whole thing without any tragedy here at home.
In closing, I want to make sure that we mention that if there's anybody around you that you see that's struggling with all the stress going on right now, remember our mental health resources are still there. And a lot of times that when you see someone struggling, there's just some need that's not met. So reach out to your friends and ask them what's going on. If there's something that they need, we have a lot of resources around us right now. So just make sure that you're keeping an eye on the people that are around you.
Yeah.
Right.
And this is, somebody said, we got this. I would tell you that what I've seen so far and what I know this system is capable of after going through the hurricanes a couple of years ago, yeah, we're going to shine. We already are. And the community is behind us, and they're looking to us to keep them safe. And you see it in other places around the world where they're applauding at shift change as the first responders and hospital workers go in and out. So I have every confidence that we are going to shine through this, but it's going to take a lot of work from all of us. All right. And with that, I think Eisenhardt's question got answered. We'll put the recording up so you can rewatch anyway. And so take care, everybody. Be safe. And thank you, Billy, for that. I might need a hug, but that would violate social distancing. So have a good weekend. Try and get some rest. And we'll talk to you guys early next week.
All right, we all good? We're off?